So what I have here is 0.3 ml of lidocaine and the connector and the Lillock syringe of Radiesse. And now I will try to be very gentle, carefully keeping the syringes. Usually I do it very, very quick, and if you have 2 Lillock syringes, that works also very easy. Now I will just be a little bit slower, but you see what is happening if I would mix it just once. I would have snake of Radiesse in a little bit of lidocaine. So therefore, it is necessary to do it a couple of times, back and forth, and then I will go to my patient to analyze her face. I must say that's her first injection ever, so she's a little bit nervous. So we hope everything will be fine for her. Will take time, but if she needs some break in between, just to let you know. For the picture. Okay. Oops. Now I have it in the nose. So, okay. Okay, and now I think you clearly see it becomes really a confluent mass, and it's not a snake in a lidocaine anymore. As I already mentioned before, I usually inject with 0.9 in the syringe, and now I will turn to the patient, but this is actually the whole mixing. This was the standard with 0.3. If I want to do hands, then I take usually 5 ml syringe and take 1.5 ml of lidocaine. Okay. So as I said, my patient never had any injections. Maybe you sit upright, because I always say, to analyze the patient, I usually inject also my patients sitting more or less upright like this, because then I see the maximum effect of the gravity. If the patient is lying back, you have a wonderful lifting effect. Because, okay, I think this is a bad position. Now I'm just having a 2 pens, nothing happens. No injection, no needles, no syringes, nothing. So the one thing, as you see on my patient, she's actually a good patient to show all different types of the aging process. She has some mimic signs. Yeah, I will paint on that side. She has, this is now just a general, she has a pretty prominent mimic. When she speaks, smiles, you see, can you smile? Yeah, she has some periorbital lines, she has a little bit of the glabella. So this is what we effectively treat and do every day and can do with botulinum toxin. Whatever you use here in Israel, every country different a little bit. But what we see in her probably, when I go in front of her, okay, so her face is not really having an obvious asymmetry. But when she would be my patient and coming to the door, the first thing that I see in her is actually a very deep nasolabial fold and a ptosis in the volume loss in the mid-face. So the nasolabial folds seem to overlap the nasolabial triangle. It will not be the mimic as long as she does not smile. Some patients come and they have so deep glabella fold, that's the first thing that you see. So she's a typical young patient, slim patients, and they develop the more prominent volume loss in a very early age. And as my cameraman is now asking me to go on this side, I do that to mark this. So when I look at her, what does she have now more into detail? When I look a little bit for the skin quality, of course there are tons of objective measurements. But do you do it in your office every day on every patient? No. It's nice for the studies, but not really for everyday practice. We see actually, she has actually a lax skin. I would say this is rather a moderate, it's not very severe. The skin is not really very, very thin, but it's also not this kind of a heavy, saggy, thick sebaceous skin. And this is why she has this kind of ptotic overlapping, a little bit a kind of the marionette line sagging, and accumulation of the legs skin in this area. When we look at the mid-face, and when I palpate here, to be honest, it's not really that much fat that I feel below the skin. It's a skin. I feel the portioning of the ligaments. She does not have fistulas or edema in the malar mouth area. And what I see when I pull down, it's exactly what is happening in her case. Due to the volume loss in the mid-face, the superficial nasolabial fat pad is overlying the nasolabial ligament, and we have a very deep account of the overlying nasolabial fold. When I look a little bit more closer to her, there are two other areas that I see. The one thing is a little bit less on this side, it's a little bit more prominent on this side, therefore I will show you on this side, is the temple atrophy. So now imagine we're always saying, oh yeah, volume, cheeks, volume, cheeks, volume. But if I would put too much volume in her cheeks, doing like this, or on this side like this, yeah, the temples, they would even appear more hollowed, and I would definitely not have a smooth, harmonized proportion in this area. So therefore, I would also inject, in her case, when I speak about the full facial approach, also a little bit in the temples. And maybe one thing, we are colleagues, and we don't, that's what I don't do with Radiesse. I rather do it with the low viscosity HA. She also has this kind of the hollowing, deep set eyes. This is where I use the HA and the cannula to inject a little bit on the inferior border of the superior orbital rim. This is definitely not something that I do in the first session when the patient is coming to my office, because they usually don't see it. And of course, this is a high risk area as well. And I never inject more than 0.1, maximum 0.15 ml of HA per one side. This is just additional thing. Of course, what I would do in her, I would do the full face all around here. I can go also with my Radiesse a little bit in the cutaneous upper lip. Of course, never into the body of the lips, and also never in the contour of the lips. But as she has also a little bit of the skin laxity, again, it's about the moderate, in the upper lips, I can do a little bit of the tightening with Radiesse. Very, very carefully. I rather prefer to use a cannula here, and I leave about ½ centimeter, something about that distance to the body part of the lips. A colleague of you just asked when patient was lying here, but she does not have jowling here too much. No, she does not have really that much jowling. When we look from the profile, it's a minimum of jowling. She does not have fat actually in the face. So if I don't have that much fat, what should protrude? But why I like Radiesse in this case is because if we speak about the fillers, I don't want to make her broad. If I would take any kind of volumizing AJ, I would make the jawline much broader. And it would be a pity because she has a very nice facial shape. What I want is just to diminish this kind of laxity signs and to lift this here a little bit, to smoothen it and to have a better feeling on the skin. This is also not a kind of the immediate effect of Radiesse. This rather belongs to the long-term stimulation. So this kind of the tightening is also why we like to use our non-ablative or ablated fractionated lasers, radio frequency, or now getting more and more popular is the microfocused ultrasound, the HIFU, the Altherapy, because it's a really completely non-invasive. And this is not only, she is a patient where you can get also very good results with non-ablative fractionated lasers with radio frequency, but especially in those patients who have a little bit more jowling. The lifting effect with non-ablative fractionated lasers is not really that good, and those patients are really ideal candidate for the Altherapy. One difference also, for example, to non-ablative fractionated lasers, I use a lot of my Icon, some of you know it, 1540, they don't have even erythema. So all of these women who wants to come in the lunch break for their treatment and go back to the office, I'm not doing my 1540 lasers, but if I do our therapy, they can do that as well, really to lift the skin here. And also with these different transducers that we have, if I just want to improve the skin quality, I can choose my 1.5 millimeter transducer, and then I'm in the same depth like the non-ablative lasers, and then also have the impact on the skin quality, not that much on the lifting. That's where I need the 4.5 and 3.0 transducers, just to cover this topic as well. Okay, so what do I do with my patients now? As I'm not sure if she is clean completely, I will mark first and then I will clean, because especially when we use cannulas, it's very, very important to clean the face as maximum as possible, to work as sterile as possible. It's not always easy on stage, so if I sometimes do something that is not really 100%, forgive me, in the office, of course, everything should be as perfect as possible. What do I do with my patients? So I have marked, or I have analyzed and recognized my main areas of, let's say, aging signs. Later, I will probably do a little bit here and a little bit of forehead atrophy as well. But when I look now, I have to mark my face. As I told you, standardized marcation. I mark my infraorbital rim. She's actually a very good patient because she does not have eye bags, she does not have malar mouths. She has a little bit positive pinch test, so I will never go with a toxin there. Also with filler, you are careful. The next marcation line would be the zygomatic arch. The ala tragus line, I have to find my tragus. And then, and usually to find the apex of my cheek, I connect the lateral epicanthus with the orbital rim and then go perpendicular, and this is this area where I want to have my apex of my cheek. It's not, in usually in my case, it's never one point, it's the area. And this will also give me a nice lifting and the projection effect. What else is important? When I look at my patients here, to look where is my ligament. So when I inject from here, I don't want to go to further lateral. If I inject too much product here, what will happen? Then I will have exactly the jolling. So I will stay rather medially here. And you see, what is she doing? She's having a pretty strong DO. It results even in a dimpling of the skin here. So I would usually pre-treat her with the toxin all around the face first. Okay, what else is important? I want to do a little bit just stretching rather in the jawline. So I look for my mandibular angle here, pre-jaw sulcus, and she has a pretty nice chin actually. That depends. In some of my patients, I sometimes do just one point a little bit here to have also anterograde stretching of the chin. Her line is actually pretty fine. It could be maybe a little bit. That's all what I do. So, and then, very important, even when we work with the cannulas, you have to take care, and I said I want to go to the temples. I always palpate for my superficial temporal artery, starting in the pretragus area, and I can feel my superficial temporal artery here, with the frontal branch going up here. Then, what is also where I don't want, I mentioned it before, I palpate for the infraorbital foramen. Why? First of all, we have a nerve here, so it's very painful for the patient. She feels probably a little bit when I play around it, so it's here. But we also have the infraorbital artery there. And there are cases in the literature of cheek necrosis exactly in this area after the injecting there. So we have one vessel here, and another, what we of course are afraid of, is the facial artery. So if we ask the patient to clench the teeth, we can very nicely palpate the facial artery coming over here. It's usually about finger a bit in front of the sternocleidomastoid, or in a patient when it's slim like her, you can feel it. And then there are different courses. It usually curves around here more or less, going close to the dangerous area, the ala nasi, and then becoming the angular artery, going up here, having the anastomosis with the dorsal nasal artery, and giving then the branches. This is also very big individual variety. Either it's the one branch first and then the superior labial artery and inferior labial artery, or the one is going directly from the facial artery. There are also different variations. So where will be my injection points? You have seen already my marking. Where do I want to have my vectors? I find it on my patient. I want to have the lifting in this effect. So I have to do the lifting in this effect. This will in this direction. This will be one insertion point. The first one is usually it's the middle of the zygomatic arch, because here we can address the lateral soothe and also a little bit superficially into the middle cheek fat when we go a little bit superficially for the lifting. But from the same point, I can also, as I'm using a cannula, when I inject directly hypodermally in the temporal area, I'm above the temporoparietal fascia. That means I'm also above the superficial temporal vein, and I'm above the zygomatic branch of the facial nerve. So that means it's also less painful. I can inject directly hypodermally with the cannula up here in a safe manner. If the patient is having very thin skin and you use Radiesse, you can dilute it a little bit more, just in order to make it really evenly distributed. Always making sure that you inject here close to and a little bit also of the distribution over the temporal fusion line. Then my next point for the lifting of the midface would be in the prolongation of the zygomaticocutaneous ligament, about 2 centimeters laterally from the ala nervi, never injecting here in this area. Why? If I inject more here superficially, what will happen? More deeper nasolabial fold. So I rather want to inject in a little bit here to fill up this area, but really in this direction as a fanning. What I sometimes do, I'm very careful with Radiesse to take a needle and go down deep here really to the bone, rather a little bit almost behind the alar, and to inject a small bolus of 0.1 on the bone to have a direct lifting. In many patients, you can feel this depression in a canine fossa. Sometimes I do it even a second step. In her case, as the nasolabial fold is really, really deep, I would also inject always a little bit directly into the nasolabial fold. Then we continue with the hypodermal injections. As I said, this will already be a hypodermal. So where is the prolongation of my vector? Here. I could very frequently, I take the same point that I use here and then do hypodermal injections, prolonging around here just to give a prolongation of the vector. Remember the mathematics addition of the vectors. And then either we very carefully take the normal dilution or dilute higher, because this is just for the skin tightening. And there is just a study going on with the different dilutions of Radiesse, how much can you dilute and still see the neocollagenesis effect. And they went up even 1 to 8. And up even to this dilution, you can see a little bit of the neocollagen. So if I do 1 to 1 or 1 to 2 and do just a little bit of the hypodermal scraping here with the maximum of 0.2 to 0.3, we don't need more, then I really have the effect just on the skin quality and not doing a broad Angelina Jolie jawline. Because not Angelina Jolie is a wonderful, pretty woman, but it would not fit to my patient's face. So, and this would be a little bit along here, as I have shown you, combining with the pre-auricular injection from here, zygomatic arch, and another one injection would be around here like this. Here, I never inject because this is also what makes the jawline more saggy. Okay, so we start, and I first disinfect. This is with alcohol, so I will try not to drop into patient's eye, so she starts to cry even before we start to inject. Okay, now we take the dry one. Okay, and now we will check how we manage it with the positioning of the patient. Okay, so, okay. All good? Okay. Okay, so I have now my Radiesse. I will use a 22G 5 centimeter long cannula. Oh, it's here. Okay. Okay. Mm-hmm.
This is
The pre-insertion. Yeah. Okay. Okay. I mix one or twice again because it was staying there for a couple of minutes, and then leave this one here and connect my cannula. And then I do my pre-insertion point, the first one. Can we bring that on the other side somehow? Or maybe someone can assist me? Just take, okay. So just relax. So as I said, my first insertion point is at the zygomatic arch. I pinch my skin and just a small insertion there. We have this kind of cover. Okay, I give it to you now. Here, and I take this with me. Okay, so. It's a little bit more comfortable, and I'm not too tall for my patient. I hope you don't mind. Okay, so as I said, I will start first along the zygomatic portion, especially in the lateral soothe and in the, when I inject more superficially into the superficial cheek fat compartments. But this is just about 10 to 20%. What I do first is now touching my first resistance. It's a smash, a little bit rotating. Now I'm in the deep fat compartments. I always try not to scrap on the bone because this is not nice on my patient. Touching the tip of my cannula. Make sure, especially if you're choosing a very long cannula, that you don't go into the superficial fat compartment or in that area where you don't want to be, but we are below this mass anyway. So, and then I do a very, very small boluses. It's usually about 0.05 in this area, maybe even less, because she's a very, very skinny patient. And I promised her not to change her too much. Don't inject too much when you are coming close to here, not to make face too broad. And then usually I do around 3 fans. And as you see, I'm injecting very slowly because I want my, my lido that is in my Radiesse to have time to start working because it's her first injection, don't forget that. Okay, and the last one that is going to be deep. And you see, I'm really ½ centimeter away from my inferior orbital rim and on the, more or less directly on the bone because the skin here is very, very thin and I easy risk if I to overcorrect to have lumps. So now I do a little bit up and go into the hypodermal area below the maxillary bone. This is just the vectoring. Are you okay? Okay. And here I'm hypodermally and injecting just a very, very small amount. You see, this is completely different plane. I'm directly hypodermally. And I always use the cannulas where you can see where you are with your bevel, turning the bevel up. And what I had the resistance feeling now here are the mesenteric ligaments. In some patients, you see them pretty obvious because they have a very severe atrophy in this area, and here they have like a bulge. And what did I tell you? She is a patient with a very moderate skin laxity. You see now I have injected 0.6, but it does not seem to be so much. If I would have a patient with a very firm skin, then I would see even more volumizing effect. But this is the first step. So I use now the same point to inject the temples. But what you see already now is improvement of the contouring. I'm bringing, I always say, what do we do women in the morning? Brushing our teeth, applying the daily sunscreen, cream, serum, whatever, makeup, a little bit of powder, and then blush. And what do we always do? Where is it? What is direction or whatever? I don't want to make her, that's what my Munich patients always say, a high Russian cheeks. It's not her phenotype. But what I want to do with this area here, to give her a little bit help to find her area where to apply the blush a little bit easier in the morning. Okay, now I choose the same point. Let's see if I can turn the cannula, otherwise I have to take a needle to do a next. But her skin seems to be like a completely loosened from the underlying soft tissue. And this is also a sign of aging. So, and you see here, I'm really directly hypodermally. One thing, make sure that you are using a really 22, better than 25 even G cannula in this area here. First of all, if you have a 5 centimeter long cannula and you take a 25, this is too flexible, so you will not make sure that you are always staying in the plane that you are proposing to be. And another thing is, with 27, for example, you are working like with a sharp needle, so you can penetrate at least the veins. It always can happen with the veins, it's not so dangerous, but not nice. And you see, I'm injecting here very, very carefully and massaging immediately, just to make sure that I don't overcorrect. Okay. This is 0.2. What we have to tell our patient when we're injecting with the cannula in this superficial technique, as I have shown you now, those patients have very prominent veins there. As we are doing a mechanical stressing on the veins, they might become prominent for the next couple of days. They go thereafter away because you have covered them, but first of all, they might get prominent. So, and now I do another 0.1 that I have in the posterior part here. This is rather as a prolongation of the lifting vector. And here, I'm always very, very careful still, even if I'm in a superficial layer, because I'm very, very close to the superficial temporal artery. And one thing, the anatomy, technique, everything, to know where you are, to know the product. This is how you prevent adverse events, but it's also always the speed of the injection. If you inject like this, tons of the material, probability that you hit one and you don't even observe it is probably higher than if you do another one. So you see actually now, it seems like the eyebrow is slightly lifted, and this was 0.3. But you see the phenomenon that I have described before, the vein is becoming a little bit more prominent. So this is gone after 1 week latest, maybe even earlier, but we just have to tell it our patients. And you see, Radiesse, even injected so superficially, it's very easy to massage it and to distribute it without lumps and bumps. So this was a half of the syringe, or 1.5 mixed with Lido. I take another half. No, I still have here another half, and then we can mix the second syringe.
Okay.
Again, I mix it back and forth a little bit, just to make sure that, okay, that's fine. I take this one from you. Can you take this? I go to my next insertion point. I have to be careful here, some like spikes. You still okay? You're fine? Good. So, and you have seen now one thing when she's smiling. I have actually corrected already partly the depression that I had in the cheeks, but what I want to do now is put a little bit more in this medial part to lift this portion, and then I will continue with hypodermal injection. So, as I said, I go in the prolongation of the cutaneous ligaments here. And I also check for my point, so I usually take it here so that I can really do this kind of lifting and this kind of lifting from the same insertion point. Although I never speak about 4 points lift by Pavicic, like some other colleagues. Okay, again, we do the same. I stretch the skin. I feel the first resistance. It's my SMAS. I don't want to go above my SMAS, especially not in this area. That's for sure that she then will have a bulge there. I pinch the skin. Great camera position, by the way. And go through the SMAS. And in this area, especially the closer to the eye I come, I try to be really on the bone. And now I just touch the bone. That's what probably she can say. In the most apical part of the deep cheek fat pad, and when we come a little bit lateral to the medial soothe. I'm not going to inject up here in the real tear trough. Radiesse, although there are even publications on that is safe and clear, I prefer to use HA there. Just because we know this is area that is frequently associated with many, many complications. And I stay in the same layer, doing a little bit like a fanning, keeping my finger at the orbital rim, and doing like the fanner to cause, to create the next cheek portion. Okay. I hope you can see everything.
Do you want us to delete the second?
Yeah, this would be great. Okay, and then the lateral one. Okay. Okay. And this altogether was 0.25. Okay? So I take now the same point, and I will maybe add a little bit more material, to be honest. I just want the lidocaine to be there first, and then I still can add a little bit more material just to make it more comfortable for her. This point for me is also the one that I can go further medially. But here, I stay hypodermally. Going medially of the nasolabial fold, as I said, about ½ centimeter, stopping in front of the vermilion. And then just doing your vector prolongation and stopping, feeling it at the nasolabial ligament. Later, I will do one vertical line on the nasolabial fold. Some people, when we were injecting just the nasolabial fold, like about a couple of years ago, were speaking about the fishbone technique. And I can also go a little bit deeper in this area here, trying to touch the bone at my canine fossa and apply, let's say, 0.1, 0.15 there, and you see the nice lifting effect up there. Even if I'm using a cannula that is 22, that is almost impossible to get intravascularly. What you have to be very careful, of course, not to inject too much material there because of the compression. Okay, so patient is laying, but you see the pretty clear difference from this nasolabial fold and this nasolabial fold. It's not just the gravity effect. So I will continue from the same point, the prolongation of the vectors in this direction. And I already see that I have to place from this point a little bit here. But that's a nice thing on the cannula. You can use the same insertion point again and again. Okay. So this is where's the tip of my cannula. Again, here I have to be careful not to inject laterally from the nasolabial fold or laterally from the mandibulolabial ligament, because then I would exaggerate the overlying superficial fat pad. So I try here also, usually I work much more with my cannula if the patients know me for a couple of years. I try to detach the attachment of the depressor anguli oris to the skin where we have these depressions. Be sure, so for what I do here, for example, I'm not injecting now, but I do a little bit of subcision of my ligament at the mandibular, at the oral commissures. Okay, here we go. And a little bit here laterally, but not directly into the oral commissures. Okay. This was, now I have so far injected 1 syringe of Radiesse. So it's 1.5 ml. So probably all together I will need 3 syringes. For the full face, it's about 4.5 ml.
This is ready with 0.3.
This is ready?
Yes.
Okay,
with
perfect.
the lidocaine and the periphery. Okay?
Okay, super. And it's the...
With the cannula.
This is another one.
Yes, it's a new one. You can throw this one.
But this is short.
Short.
I take the another one.
Let me.
Where do you have?
This
Oh,
one?
yes, here.
Wait, wait. I have it.
Okay.
This one.
Yeah. This one, that's what I want. Okay. Let's go a little bit here, the last 2 points, and then I will finish this one area here. This is sometimes a very tricky area, the buccal fat pad. This is deep processes of the buccal fat pad in many patients. It's so deep, you can go with the bolus, you can go with the cannula. It never works in one injection session. So I tell my patients to come after 4 weeks, and then we add a little bit more material before I cause them a big bulge there. Okay, continue with the jawline. This is what I said, it's rather for the skin tightening and a little bit of the lateral lifting. So I go actually at the attachment of the pedicle, hypodermally. Thank you. Stretching the skin. And introducing my cannula. Really, really superficially. Okay, here we are. And you see, I'm going to cover the whole area up to the preauricular area. She's not really hollow there, but many patients are very, very hollow there. Just a little bit of the material. And you see how minimally I'm injecting. You don't see the product. I was frequently asked by the colleagues, are you not afraid that radius might become visible? If you distribute it evenly, and especially when you're using a cannula, you still have the whole dermis above the product that you're injecting. Okay. And you really see how flax her skin is. Okay. Do just a little bit more up here when I'm anyway here. Can I have the wet? Yeah. Thank you. I have drawn. Thank you. Thanks. And the needle. Once again. Okay, just refreshing a little bit the insertion point that I had. Voila. Okay. And here I go hypodermally. Okay. Here we go. I was speaking about the blushing areas. So you can give me some more questions from the audience.
Is it recommended to work with the cannula?
Is it recommended to work with the cannula? If you ask the cannula queen, yes, it is. But to be honest, I feel I inject, of course, a lot of AGA also in my office. With AGA, I feel both very comfortable depending on the area where I am. With the needle and with the cannula. And you see now I have smoothened this area. With the Radiesse, you see how I work. When I work here, especially in this lower area, I really strongly recommend cannula. First of all, you see how much I work there. If I do it with a needle, you know how bruised patients will be? So the one thing is the patients are afraid to be bruised. Another thing, as I already explained, when I do my cannula, I do subcision. So I have already mechanical stimulation for the more neocollagenesis effect. And according to my experience, and I observe my patients, you have a better effect with the cannula. And you don't need more material if you are trained with the cannula. Okay, and you see now already, I'm not even sure, maybe I put a little bit here. I could do it also with the needle, just one small bolus in the pre-Joel sulcus. Exactly, you see here where is the attachment. But I can do it actually from this insertion point as well. This is probably what I would do in her, and then I let her, and a little bit directly into the nasolabial fold, and I have to do a little bit more on the temples. Can you give me a needle once again? Oh yeah, here, sorry. She probably has the feeling that the half of the face is feeling now like a big, big, big. But this is because of the lidocaine. It's not big. I have to work very careful here because I'm going around the vessel. And now, okay, by the ligament. And this is also the area that loves to get bruised. So I'm trying to palpate. And you see, I'm exactly there where usually my needle would be. See the plumping up. And I'm on the bone, touching the bone, and doing what my dear friend Gerhard Sattler would say, a sweet point injection. And then a little bit of hypodermally just to support the tightening effect and the mobilization of the submental ligaments. I promised I want to do a little bit the chin, and from this same point, they go a little bit to the mental crease to improve this. And we all know mental crease is very difficult to inject and to treat. What I sometimes do is to combine again, to do radiesse like here with the subcision, and then after 2 or 3 weeks, maybe even 4 weeks, to do HA in a blanching if patient does not have too large pores. You can't do the blanching with the too large pores because then you lose the material. So, okay, let's have a look with these 3 points. I'm getting always less and less. I haven't injected so far into the nasolabial fold just because I want to show you a real lifting effect. And as I said, I would add a little bit more into the temples, especially in the apical part here. But I have to be very careful. If I lift her eyebrow too much, I will exaggerate the hollowing of her upper eyelid. Look at here what is happening. So her eyes looked like empty. Like when you see the patients who had the upper eyelid blepharoplasty and too much was cutted out and the eyes look like a very deep set. So far I have injected, I would say, 1.5 mixed syringes, maybe a little less. I still have 0.8 left. So even a little bit less than 1.5 syringes. Can you maybe sit upright? And I haven't massaged so far, so I haven't touched her. This is just how I do it when I inject. And maybe you look here in the camera to here. Okay. So I should remove this. So what you see is exactly when we look that we lifted the nasolabial fold here, but as I told you here, I would do a little bit more directly into the line here. The jawline here, you see exactly the shadowing here into the prejowl sulcus. Here is rather smoother. The temples is not as hollowed, but I missed a little bit here. That's exactly why I said I need. And when we look from the profile, we see now a very nice cheekbone, and where the blush should be, it's there. So it's 1.5 syringe of Radiesse for the total face. And even when I finish the nasolabial fold, this will be. For the nasolabial fold, you can use a cannula if you go hypodermally, directly, a little bit rather medially, or you use a needle. But then I always say, if you use a needle in the nasolabial fold, rather be deep dermally. Okay, I just add a little bit in the temples. Maybe, do we have a mirror? Yeah, then we show you. Oh. You like? Okay. Okay, now I finished this here, and then maybe we can take some questions. You can lean. I think it's more comfortable for you, isn't it?
With the needle?
No, I don't. I don't think. Let's see. Maybe yes. It's better. And then maybe we can take some questions, and then I finish the other side. And for those who want to go, then we have questions. Can you lean just a little bit your head up there? Thank you. Okay, so it's very painful. I'd rather leave it. Okay, now we are done. Okay, now it's nice. Yeah, yeah. So I do now a little bit into the nasolabial fold, but as I'm finished with one side and another side is just repetition, maybe we can wrap up a little bit and do some questions. I know it's very late for those who want to go home. Some more questions? Okay, can you give me the needle? Okay. No questions, I can't believe. I have to look at them to see that there are no questions. So here I'm in the hypodermal layer. I can go up even to the dangerous area because I'm using a 22G cannula, but still, of course, very, very careful. Okay. So I have put now here in this NLF, it was 0.1. Sorry, normal dilution. This was everything what I was doing now was the normal dilution. And this is now 1.5 syringes. Only the white lip. Radiesse never in the body of the lip, never into the vermilion, never into the red part, and also not in the contour. Even if you're using cannula, no way, especially not in the contour. That's almost for safe that you will get the nodules. And I also leave always about really a couple of millimeters, let's say 3 to 5. I don't really put a linear and measure it, outside of the red part of the lips. And as you have seen, for this portion, I was also injecting about 0.1. Really a minimal amount, because what we also don't want to have, especially if we're using a standard dilution, you also have a volumizing effect. You don't want to have overcorrected duck lips that you frequently see with any kind of product, but I mean here I would get even more volume comparing to the same amount of the HA injected. Maybe I give it to you, then I go a little bit in front. When they see me, then they... No, it's fine.
Lean on me.
Therefore, I put off my high heels. Okay. And I think actually on her face, what you see, the best effect is really on this area and on this area. That is also, I would say, if you ask me, what is the most prominent concern if in her face, these are the two areas. More questions? Yeah, and this is what patients say always. They feel like the face is so big. This is rather because of the lidocaine, and of course we were doing. But you have seen one thing. I think it's also a little bit how do you inject. I inject very slowly, very carefully. Still in my office with assistants and not talking and the patient, usually it takes you 20 minutes for the full face. And the very sensitive patients, those, you know, when you do a little bit touch, and it takes me maybe 30 minutes for the full face. This is okay. And she was great. I mean, really, I have different experiences always if you have patients who are injected for the first time in front of such a big audience on stage, so many lights. After 5 minutes, you just so and think, she's really great. Okay, some more questions? Who actually, I should ask at the beginning, who has tried Radiesse so far? 1, 2, 3. Oh, it's a cameraman. Just 2 physicians? Okay. Who will try it? Okay. Okay, if someone wants to have one-to-one hands-on training, you're also welcome anytime to come to Munich and visit me. It would be my very big pleasure. And I always find some volunteers, some patients who always let other physicians to inject them. Okay. Do your company something want to say? I mean, now continue to inject, but I. Okay.
Maybe we'll do the other side and just
Yeah.
summarize it?
Yeah, whatever you like. I mean, I just thought maybe someone want to leave.
Okay.
Therefore, I thought.
Okay. So just give you the needle.
And then you can.
Before I go.
Yeah. You know, because I think it's late and people.
Yeah.
And it's just repetition. And you feeling still good? Are we good? Okay. Oops.
That's okay.
Yeah, that's just water, and I touched. Okay, you need to turn a little bit more. Yeah. Okay. Okay. It's just a little bit difficult somehow to get here. Okay. Here we go. Okay. Okay. Now we are in. Okay, I do the same again on this side. Very small boluses, very careful. Like a 3 lines. It's actually nothing really difficult and strange. The injection pressure is, I would say, comparable with volumizing AJ, maybe even easier than some of them. We all know that even AJs have different injection pressures. Okay. Now I can't watch to the audience because I'm looking somewhere else. Okay, so now we are in the temporal area, and I like this point actually. I've also used the cannula to do the eyebrow lift. I haven't shown it in her because it's not really necessary. But when I do the eyebrow lift from this point with the cannula, then I'm not hypodermally, but I'm going along the orbital rim, above the bony margin, but on the bone into the roof to lift the eyebrow. Just changing the depth of the cannula. Is this one pre-mixed? Where are my assistants? Is this one pre-mixed or not yet? It's ready? Okay.
Two ready syringes.
Oh, okay.
So what do you need?
This one to plump it up.
I'll take it.
Okay. Okay. Take a shot. Do you want to drink something? Do you want to drink something?
No,
Nothing.
this is for you if you want some water.
Yeah, no, I'm fine. I'm fine.
Brehol or something? You don't
No, we have already yet. No, we don't need it yet. We will need it in a couple of minutes. Or maybe give it to me. It's a little bit more comfortable for you and for me as well. Okay. Maybe if you ask me, or if I may, you don't ask me, but maybe if maybe this is a question also that is important to share. If patient had radiesse, can I inject AJ over it? Yes, you can. As I said, if it's in a different layers, it's not a problem at all. I personally do it sometimes even in the same session from the company. It's the official recommendation, wait for 2 to 4 weeks. Just in case, you know, if patients swell more or any other, of not severe, but rather minor adverse event happen, that you know where it's coming from, just for the next time. When can I do a laser after radiesse? And there are actually a good histological studies with several fillers. How can we combine and when the lasers over the fillers? That's not a problem also with radiesse. Especially when you're using a cannula, because all of our lasers, they don't get deeper. The only thing that you have to be a little bit careful is probably when you're using the fractionated CO2, because if you're injecting superficially radiesse, for example, with the needle, you might get also down to the deep dermis, and you might have a certain ablation. Nothing will happen, but you will just ablate the product. With thermage, radiofrequency, there are also studies combining it with radiesse that you can do it, I have to do a little bit more, that you can do it immediately thereafter or after 2 to 4 weeks. I would always recommend to leave at least 4 weeks, maybe even better 3 months. Because then you give actually radiesse a time to develop the neocollagenesis effect and not just doing a double thing. What I have observed, the same with our therapy, my patients, when they had radiesse about 3 to 4 months before our therapy, and then I have done our therapy, especially for the lifting in the lower face or in the mid-face bar, they had a quicker response, so better visible effect or significant effect even after 6 weeks. Usually we say 3 months. So it is actually reasonable and it makes sense to combine it, and we can combine it. Okay, now we do here, needle. And you have seen many of my colleagues, they do the local anesthesia at the insertion points of the cannula. My experience is rather if you pinch the skin and then just very carefully use the 21G needle, that it's not very painful. Not more than the local anesthesia of the lidocaine that burns anyway. And I know when I do my knee excisions, many patients say, oh, this burns even more and it's even more painful than anything else.
So actually this is only the beginning of the third
Yes, this is now the beginning of the third syringe, exactly. And you see now, if I don't do the temples, I don't even always need this point. If I don't inject here, I can do the cheeks from the one point as well. This is usually how I inject, for example, AJ.
Do you always dilute the radius?
The question, she asked me if I always dilute radiesse. Thank you that you're making some questions. To be honest, I almost always dilute radiesse. The only thing where I don't dilute radiesse is when I do the chin, especially in Asian patients where I need really a lot of material. And it's usually 1 or 2 points, so it's also not really reduction of pain if I use a lidocaine, and it's what I use with the needle. Or sometimes just the radix of the nose, but I really use more HA in the nose than radiesse. That's. But I have also some. Sorry, this is always a little bit tricky area. But now we do a block there. Okay. No. We'll wait a little bit. This is the plexus there of the nerves.
Oh, she's tired.
Yeah, everybody, I think. Now it's getting long. I have to speed up a little bit, I think.
So you dilute it in order to improve rheology?
I dilute it in order to make it easy injectable for me, especially if I do it like this, to make it a better, easier to distribute, like we see here, and also to reduce the pain in the patient. Because radiesse, when it's not diluted, it burns really more and it's more painful because it's more viscous and it's more elastic, so it will more stiffer. Just a little bit. It may take a small break. Oh, make a short break. Because you do a more pressure on the tissue, and when you do more pressure, of course, we have more secretion of the substance P, all the neuropeptides or whatever is involved into the pain creation. Therefore, it's easier. And especially when you inject here, it's even then it's really, you have a risk that you see some visible lines when you inject it there. Okay. I take the needle now and then go here, and then I will come back here, just that it works here a little bit more. No, we don't let her asymmetric go home. No way. And what I tell my patients, maybe as a home, what to do and what not to do, I usually massage it in my office as much as they need. They don't have to massage it at home. Not these rules like with, with the PLLA, 5 times a day, 5 minutes, or 7 times a day, 7 days, 7 minutes, or whatever it is. Depends on the country where you are. And usually they can behave whatever they like. I only think, always say, don't go to the sauna for the next 1 week. For example, in Finland, very difficult. They look at me like I would be crazy. In Singapore, they laugh on me and said, we don't have sauna, we'll live in a sauna. And of course, when I'm using a cannula, I'm using a big cannula, 22, so I do a significant insertions points. So I tell them to be very careful not to apply too much makeup over these areas. Or I discovered something in Korea. There are these very, very tiny skin-colored, tapes. And you can cut them very small, put them over it, and patients can even apply a makeup over it, so don't see it at all, but the insertion point is protected. Okay, here we go again, it should be blinded there. Okay, now we do the upper lip, and you see I'm very, very careful here, staying medially from the line. Sorry. Can I have a needle? Can I have a needle?
Needle, of course.
That's for you. That's for me. So I go back here. This was okay, I think. Okay.
Sorry, Kitty. זה כמעט נגמר. Almost
The second last, almost gone. It's been a long evening.
Yeah, for a model it's not easy also.
Yeah, and in first treatment and immediately the full face, respect. But then you know that you have something done. Not suffering for nothing. The contraindications maybe for Radiesse, who should not be injected, of course, like with all stimulatory kind of treatments when we do, is patients with a known history of keloids, hypertrophic scars, autoimmune diseases, active autoimmune diseases. I live in Bavaria. We have a tons of people with some thyroid problems. They are not really severe. Of course, we inject them. But if they would have, let's say, active scleroderma or lupus, then of course don't inject this, especially not, I mean, it's contraindications for any kind of fillers, but of course especially not with Radiesse, because we do a stimulatory effect. If patients had a permanent fillers, I also don't inject actually anything over it. And also, where I don't inject Radiesse, if the patients had unknown fillers. So we have pretty frequently patients coming from Eastern Europe and they don't know what they got. So this is where I also say no. Because you don't want, because you're the last one that touched them, so you are always the guilty one. I think that's now just like an overtension. Everything is too much now because it's so long. But it's okay. We are almost done. She has really like the skin, you feel you could remove it from the fat underlying. Okay, now we're done. Okay. So now I do a little bit more into the nasolabial fold, and I think that's now fine. And we get you some toxin here. You don't look so mad. Okay. A little bit of massage. Okay.
Well,
this is another half.
Yeah, it's ready.
Okay, then that's more than I need, but it's okay. Oh, it's fine. A little bit cold. there are still some brave people in the audience. Okay, can we get her a little bit down, because otherwise I have to jump over the... A little bit further down. Or maybe we just take the pillow. You know what? Just take the pillow. Not completely.
No?
It's okay. No, it's fine.
That's enough?
That's enough.
Okay.
If it's necessary, I can take the pillow. Okay. Because I want to go behind her, you know.
You don't need anything?
I don't think. Okay. Some more the same area of the buccal fat pad as we had on the other side. See, as I'm injecting always in the same way, I also have the same areas to correct. And now the last one here. Now it should feel also a little bit numb from the lidocaine. Okay. So. Okay. And now we do the nasolabial fold, and then we are fine. I can use this point also to go a little bit up here. Okay.
So it's a full face with 6 ml.
Full face with 6 ml. I think you had a little bit left over there.
Yeah, I have.
Because it's about 5 ml that we have now really injected. Usually I would take 4.5 because then it would be 3 syringes.
Yes.
So 3 syringes for the full face in her case. And what I would probably do, I let her come, so we come with the 6 ml maybe when we do I let her come in 3 weeks or whatever. And then I would do in a certain area a little bit, maybe the touch up, you know, whatever it is. And you can do it with Radiesse as well. So for example, here if I say I want to do, you know, a little bit more here or here, and that's what I sometimes do. Then I take a needle and do it really pointed in the area where I want to have.
Oh, she's tired.
Yeah, and we are finished. And of course, I would now take care to massage a little bit, to tell her to put a cool pads or whatever. But actually, as you see, it's not a massive swelling. There is no bruising, no hematoma. The only thing where I advise them is a little bit to massage the temples for the next 3-4 days. And then to, as I already mentioned at the beginning, to tell them that the veins are a little bit prominent for about a week, but this sets down.
Yeah. You have Biofin if you like to use it.
What is that? This one? Oh no. Tell my patients, this is what I tell them, if they feel something, a little bit, I have to go the other side probably, then they should massage as well, of course, and not wait for 3 months to come back and tell me, oh, there is a nodulus there. And as here we don't have a bone, like a resistance, you can actually use your finger of the opposite hand to inject it. Finished.